Okay. Hi, good morning, everyone. Thank you, Russ. Sorry. I just want to start by thanking TERI and the organizers for giving me the opportunity to talk to you guys today. TERI told me, you can talk about anything. It doesn't have to be about your work. It can be about anything at all. And so I was thinking, what should I come and talk about? But you know, I've been in the field of pharmacogenomics for 20 years now, a long time. And I think it fits in pretty well with some of the themes of precision medicine at some of the sessions today. So I thought, okay, I think I'm going to go ahead and talk about this, but not just pharmacogenetics in general. There's like some issues that I've got some really strong opinions and views about. And so it's not really my work per se that I'm showing today, or my team's work at PharmGKB, but just some issues that I've been thinking about over the years, particularly pertaining to genetic testing and how genetic ancestry and allele population frequency play into that. So these, again, are issues that have come up in this conference over and over again, looking at genetic ancestry and diversity and health disparities. And that applies to pharmacogenomics as well. So I'd like to say first, for my colleagues that are already in the pharmacogenomics area, I apologize. This is probably going to be boring stuff for you guys. You know all about this already. But for everybody else, I'm hoping that it's something kind of new and maybe relatively interesting to you guys. So I'm going to start by talking about what is pharmacogenomics, right, for people who aren't super familiar with this area. So I stole some slides from lectures I give when teaching students, genetics counselors, pharmacology, pharmacy students. So they might be a little hokey, but bear with me because this is how I explain it to students as well. So we're probably all familiar with the fact that there's variation in how people respond to medication, right? And drug response is different in different people. So let's say we have a group of patients, they all have the same diagnosis, and they're all going to get the same treatment. They're all being prescribed the same drug and probably very similar dosages as well. Or at least they're being prescribed whatever's on the drug label as the recommended dosage. So the FDA exists out there to test medications, make sure that the medications that are available to us are safe and effective. So for the majority of the people that are taking that medication, everything's hunky-dory, they're doing great, they respond well, and everything is beautiful for them. But we might know some people who, when they take a certain medication, maybe they just don't respond to it very well. Like, just even pain relief doesn't work the same for some people. Some people will say, I don't really get any relief when I take Tylenol or Advil or whatever. This happens a lot for antidepressants in particular. People start with one antidepressant, maybe don't have a response, or a blood pressure medication. They're taking, they get prescribed several before they find something that works well for them. So some people on the same drug as other people are not going to have a really great response rate, or maybe they don't respond at all. And then unfortunately, there are often a few people, not tons, but a few people who might respond really poorly to the same medication that's working well for everybody else. And they can have anything from, just an upset stomach, they don't feel well, to something, really toxic and potentially even fatal. So even though drugs are approved to be safe and effective, there's oftentimes still variation in drug response in population. So why does this happen? Well, there's lots of reasons why, right? There are clinical factors that can come into play. There are drug-drug interactions that can cause these things to happen. But there are environmental things that can cause, medication to not work properly for someone. But we do know that there are also genetic factors that contribute to this. There's definitely variation in genetics that can affect your response to medication. And so that's what pharmacogenetics or pharmacogenomics is about. It's pretty obvious. The words are coming from pharmacology and genetics or pharmacology and genomics. Pharmacogenetics and pharmacogenomics are used interchangeably most of the time nowadays. Before the human genome was out there, for those of us that remember that time, everything was pharmacogenetics. Nowadays, most people talk about pharmacogenomics. And we just abbreviate both pharmacogenetics and pharmacogenomics with the term PGX. I sound really loud now. Is this okay? Okay. All right, so you'll hear me say PGX, and I'm just referring to pharmacogenetics and pharmacogenomics. Either way, it's how a person's genetics affect their response to their medication. So precision medicine or personalized medicine encompasses PGX, right? PGX is part of this. Just the same as we use genetics for diagnosis, we can use genetics to help prescribe medications that are going to be safe and effective for people. So using genetics to help choose the right dose, the right drug for the specific individual that the physician is treating at that time is the ultimate goal of pharmacogenomics implementation. So, and I wanted to say for my colleagues in the room, over 20 years, I may have inadvertently appropriated some people's slides. So if you see things, Lee or Katrin or Russ or Terry, that look familiar, thank you for your slides. So this might be one of them, that's why. Okay, so nowadays today, drug selection is empirical many times, right? So you go to the doctor and there's like, okay, we're gonna try drug A for you, and if that works, great. If it doesn't, then we're gonna go to drug B, and so forth. And sometimes it can be quite an odyssey to find, like I said, especially for antidepressants, blood pressure medications, these kinds of things, cancer therapies, it can be an odyssey depending on what's going on. So that's because the efficacy may vary from person to person, and the adverse events when you're prescribing in this manner can be unpredictable. So we're hoping in the future we can use this genetic testing to help guide us with the drug dose and selection. So we're starting with a genetic test, and then we know, okay, yes, drug A is probably the best for you, considering your clinical factors and your genetics at the same time. So in no way is genetics alone prescriptive enough. It's just another factor that doctors are going to use when they're trying to determine what medication to give out. Or maybe you need drug A, but you need half the dose as you would get another person. Or maybe drug B is best for you, and we're going to go straight to drug B, not after drug A. Or maybe we know we would never give you drug C. It's just not going to work for you or going to be bad for you. So the whole goal here is to avoid those adverse drug reactions, and we want to maximize how well the drug works. And so we're going to get the right patients that are going to respond to the right medications. So I'm just going to give you a little example of how this can work in practice. So a drug called clopidogrel or Plavix is used in patients that have had acute coronary syndromes or people going under PCI, percutaneous coronary intervention. So this is a commonly used drug in this area, but we know that the response can vary greatly, and there are anywhere from 4 to 20% of the people on clopidogrel where it's not working for them. And so if you think about it, you're on this drug in order to prevent you having another bad event, coronary event. So if this drug is not working for you, not only is it just, lack of efficacy there, you are at risk for having another coronary event. You're essentially not being treated. Okay. Clopidogrel by itself doesn't really do anything. When you take it, it has to be converted into an active metabolite, and that is a big player in the conversion into active metabolite is an enzyme called CYP2C19. This gene that encodes the enzyme is really polymorphic, and there are genetic variants, known genetic variants, that can lead to the function of the enzyme being decreased or, almost no activity at all. You can also have increased production of the enzyme. So the patient's phenotype, or how they respond to this medication, of course, depends, I don't have to explain to you guys, depends on, the combinations. You've got one chromosome from mom, one from dad, and you've got 2 copies of the gene, so the function of each copy has to work together to get the overall phenotype for the patient. So if you've got 2, normal copies of the gene that's functional, then you are called a normal metabolizer. It works fine for you. You have normal efficacy of the drug. But if you only have one normal copy and you have one copy of the gene that encodes an enzyme that is a decreased function, you have, somewhere in the range of only 75% maybe of the activity as the other person, the aforementioned normal metabolizer. So you are called an intermediate metabolizer. You don't have a lot of clopidogrel metabolism going on, so you have less of that active metabolite, so the drug's not working as well for you. And now if you're a person that has 2 copies that are impacted and are not really functional, then as you can imagine, you're not really making the active metabolite, which means that you can't you're not going to respond to this medication, so you don't have the platelet inhibition that you're supposed to get from this drug. You have an increased rate of platelet aggregation, and so you're at risk of having another major cardiovascular event. Okay, it's pretty straightforward. We've known about this for a really long time. FDA knows about this, the drug makers know about this, everybody knows about this. Back in 2010, so it's 13 years ago now, there is a black box warning put on this medication, and it says it doesn't work as well in poor metabolizers. Okay, and they say things like, a recommended dose, you got to be careful and maybe consider alternative treatment. That's great. We know that there are genetic tests out there that can determine if a person is a poor metabolizer. But on the drug label, they don't say that you should test. They don't say you need to test. They don't say anything about testing at all, actually. They just say, if you know that your patient's a poor metabolizer, do something different. And people don't typically test. That's just not the common practice right now. So a little bit about CYP2C19, that enzyme. A lot of metabolizing enzymes use this weird shorthand nomenclature to talk about their variants. They're called star alleles. So you have the name of the gene, and then you have the star and a number after it. All you need to know is star 1 is usually just like the regular version of the gene. And then any other number after it could work well, it could be decreased function, it could be dead enzyme, we don't know. But every other number after is a different allele. We know in CYP2C19 that star 2 is the most frequent allele with low or decreased function. There are currently over 39 different allele variations, even more if you want to get really technical with things, but basically 39. And we know that the allele frequency can vary by population. We know, just like in the rest of clinical genomics, and pharmacogenomics is no exception, that the frequencies of alleles can vary by genetic ancestry population groups. So your genetic ancestry can affect the frequency with which an allele is found. So, hope you can see this. So this is just a little part of a table, the top part of a table, where colleagues of mine have put together to comb through the literature trying to find the frequency of these different star alleles. That's over in the left-hand column. How many people are star 1, star 2, star 3, et cetera. And then we have these different genetic ancestry populations groups at the top. And I just want to highlight the group that's Oceanian, or people of Pacific descent. You can see that this star 2, which we already said was a really decreased function, very impacted allele, is a frequency as high as 60% of that population. So very common, right? Way more common than any of the other populations. So this is a problem now, right? Because we know that this group of people were probably not extensively studied in the clinical trials for a drug like clopidogrel. So now we know that the frequency is very high in this population, and yes, that was figured out here in Hawaii. I use this example because we're in beautiful Hawaii right now, talking about Hawaiians. It was not lost on the people of Hawaii when large numbers of patients were failing to get any effect from Plavix or clopidogrel. And so the state of Hawaii did decide to sue the drug manufacturers. And they said that it was basically false advertising because the makers were saying Plavix worked. And they were saying it's false advertising, putting profits ahead of patient safety. So I don't know that it was false advertising. It works for most people, but not really well for this particular population. And even though there's a warning on there, doctors didn't know what to do with that. They're not testing for it, right? So they're prescribing it like anywhere else. So, eventually, it took a long time. I think that was in 2014 that they tried to sue the drug makers. And then not until 2021, I think it was 2021 here, yeah. Not until 2021, finally that case was settled, and the makers were ordered to compensate the people of Hawaii because they did not go far enough to warn them that this drug might not work in their population very well. Immediately, right, Big Pharma said, no, they appealed the decision. And a couple of years later, about 2 years later, the drug company did get the Hawaiian Supreme Court to overrule at least part of the verdict. They said the amount of money was too much. Basically, in the end, they're still kind of found at fault, but there's going to be another trial to see how much they actually need to pay. So this does matter. This can have an effect on population, and cases like this are kind of low profile, I guess, in the main news, but I think more and more cases like this are going to lead people to have to take into account what kind of population they're using the drugs in, and just the variation that can happen in any population, the variation, the genetic variation that can happen, that can lead to different responses in medication. So this is a big version of the table. I'm not expecting you to read it. But what I just want to point out is, again, there's like all these alleles down the left-hand side. There's over 39, so cut off again, and all these different populations. And so this table, again, was put together by pharmacogenetic scientists who are combing through the literature, trying to find studies that are reporting the frequencies of alleles in these different populations. And so just note all the blank spaces, right? The blank spaces are there because they just couldn't find anything. So in a lot of populations, we have a lot of alleles where we just don't know. No one's even looked in that population, to our knowledge, and published in PubMed anyway, what the frequency of that allele might be. So, many of them have zeros in them, but I will also say to you that a zero means maybe there was a publication somewhere where they looked at 5 people, right? If you're only looking in a few people, you're not going to find some of these alleles that might even be at 10%, right? Population frequency. So these tables tell us that we have a lot to learn about what variation, genetic variation that affects drug metabolism exists in different populations of genetic ancestry. Let's see. So if you don't look for something, you're obviously never going to find it. And so some people look at this table and they say, something like, oh, star 25. Star 25 is super rare. I don't need to worry about it. I'm not going to put it on my test panel. Like, it probably doesn't exist. This is what they say. It's only been found in the East Asian population. When they look at that table, that's what they'll say. I have colleagues say that all the time. It's only been found in this population. It's not been found anywhere else. Do we know that? I don't know. If nobody's actually tested those other populations, we don't really know that. That's where it was found. That's where it's been reported. It doesn't mean it only exists in that population. So, again, these allele frequencies are unknown for many alleles, and they are way understudied in most of the populations. So that poses so many problems for us, right? So alleles not studied means things that are termed rare may not really be so rare. You just aren't looking for them. If you never test for them, you're never going to find them, and they're always going to be rare to you, right? And if we say, oh, it's rare, I'm not going to test for it, it's circular. You're never going to get there. And another huge problem with pharmacogenomics and the way that we use the nomenclature and the way that we test. That star 1 allele that I said is just like your normal version of the gene. It actually means you didn't find any variants. So if someone does a test and they don't find any variants, they're going to report out their star 1. Did they really look across the entire gene and know that it's just like reference sequence or the reference copy of the reference sequence for that gene? No. So that is a very misleading test result for research as well as in clinical implementation. A star 1 means we didn't find the particular things that we were looking for. But that's really highly misunderstood, I think, and by researchers and implementers alike. They don't really think of it that way. They just say, oh, we have a result for this patient. It says it's star 1. We think they're normal, and move on. So this is really bad. We don't want to be defaulting people to star 1. It also means that in that table that I showed you, the way we come up with the frequency for star 1, we add up all the other known allele frequencies and subtract from 1. So that star 1 frequency is probably overinflated, right, in that table, because we haven't checked for the other star alleles. Okay, so this impacts not only how things are tested for in implementation, like I said, but also in research. So, of course, we need more studies across diverse populations. Not only do we not know the existing alleles frequency, the known alleles frequencies in these populations, we haven't even discovered all the alleles that are in these understudied populations. So, very bad. That said, I do want to point out that you can't use those population frequencies in place of genotypes at an individual level. We can't go around and say, I'm in Hawaii, so I can't prescribe Plavix at all, right? Just because the frequency of having this decreased function allele is very high does not mean that Plavix isn't going to work for anyone. We can do a test. We don't have to guess. We don't have to assume. We don't have to lean on statistics there. We can test to find out what you or me or you actually have, and we don't have to guess by looking at you and knowing what you think your genetic ancestry is, because sometimes we don't even know for sure of our own genetic ancestry. We know our ethnicity, we know our background, but we may not know every detail about our own genetic ancestry. So yes, so why can't we use these population frequencies in place of genotypes at the individual level? People don't always know their genetic ancestry. We know this because things like Ancestry.com and 23andMe are in business. People love to find out these kinds of things, like what's hidden in my genetic ancestry. I thought I was this, and it turns out I am that. I see those commercials all the time. So it can be a mystery to us. And most people don't fit neatly into one genetic ancestry bucket, especially in the United States. There's a lot of admixture, a lot of genetic ancestry diversity in people that they didn't even necessarily know that they had until they were tested. Allele frequencies apply to populations, not to individuals. So the whole point of personalized medicine is that you have to be specific to the person. Okay, so we know variants are identified through research studies. The discovery is limited to that which is studied. So unstudied populations are going to harbor these unknown variants. And when we build genetic tests, we build them on what we know. So if we have a genetic test that's built on a particular population that was studied, when we go to test another population, we're not going to be able to detect those unknown variants, obviously. So those people are not going to be identified, and they're going to get a result of star 1, and they're going to be told they're a normal metabolizer and not to worry about this. This is a problem, like I said, for research as well. We have an example. We know about this. An example of how this of this happening is the story of warfarin and another gene called CYP2C9, and I don't expect you to read through this whole thing. But the point is, warfarin is metabolized by another enzyme called CYP2C9. It's also polymorphic. Many studies were done over a decade or more where we were looking to see a couple of alleles, star 2 and star 3, cause like decreased function. So many studies were done. We're looking at star 2 and star 3. What's the impact on the outcome? And what happened was we had some studies that showed genetics does impact things, some studies shows that it didn't impact things, and so the evidence was kind of all over the place, and people didn't know what to make of it. They said, maybe pharmacogenetics doesn't really apply to warfarin at all. But that's not really true. Why were there the differences between those studies? Some said yes, some said no. Well, one reason was they were looking at different outcomes, so that is a big reason. But the other reason is they were looking over and over again at two alleles that were known, that were discovered in people of European ancestry, but they were trying to broaden out their studies. They weren't testing for all the alleles that could lead to decreased function. So they were mislabeling people, normal metabolizer, especially people of African descent. Star 2 and star 3 are not the most common decreased function alleles. There are other alleles, star 8, etc., and they weren't testing for them. So they were saying, oh, you're star 1. And they said, now it impacts your statistics. You can't find a good signal if you're mislabeling people who are really poor metabolizers as normal metabolizers. So that impedes our ability to even understand what is going on and know how to interpret associations between genes and drug response. So I am going to speed through some of these last slides. So we know that these variants, we know these variants are identified, right? So in research studies. So we know we have to have better research in diverse populations. That's a fact. We have to discover those alleles, and we have to test for those alleles in order to have a really good test for a particular population. However, I've been getting this question a lot lately. What can I do? How do I deal with my population? Because what's known about it doesn't apply to my population. What we know is from maybe European ancestry, people of European ancestry or people of East Asian ancestry, and my population is not, so I can't even use what's out there. I need to start over again. Is that really true? I don't think so, and here's why. In pharmacogenomics, we're not doing a lot of association. We're not implementing based on GWAS and association studies. We are looking many times at causal variation. We know that this variant does cause a decreased function of the enzyme, for example. So it doesn't matter most of the time who you are or what population you're in. If you have that variant, you're going to have the same outcome. So no, if you test for these variants in a different population and you find it, you can do something about that, absolutely. So it's not that it doesn't apply at all. The problem is you're going to miss variation, right? It's those negative findings that are the problem. So I don't think that it's necessarily true that we just got to throw everything out the window and we've got to have a separate, test for every individual population. But obviously, we need to study all populations to identify all the variations so we can test for them. Negative results are always a problem, no matter what the population is. Sometimes we do whole genome sequencing, sometimes we do panels, sometimes we do exomes. If we limit ourselves to panels or exomes, we're going to miss variants. And again, we're going to get this result of star 1, tell people that they're normal function. That's going to go into their health record. They're going to believe they're normal metabolizers. Their clinician's going to believe they're normal metabolizers, and no one's going to look again. So even when we're sequencing, though, we only want to, many people, the field, we want to only give validated responses, right, results. So even if we know that there's variation in gene, we don't know what it means yet, we don't want to report it. But just bear in mind, that means that those people are walking away with a test result in hand saying that they don't have any variation. Because somebody chose not to report it because it was kind of scary, because people don't like unknown things. I don't want to know, I just paid all this money for a test and you don't know what to do with me. I have some variant and you don't know. Nobody likes that, right? The test companies don't like it, the insurance companies don't like it, the doctors don't like it, the people don't like it. But maybe, let's think about that, maybe it actually is important to let someone know that, so that they know as science moves on, as things change, science is where our knowledge is always growing, always evolving. We're learning about new alleles every day. We're learning about the function of these alleles every day. What we know today is not what we're going to know 5 years from now. 5 years from now, we might know what that weird variation is. Who's going to go back and say, oh, let's reevaluate, let's reinterpret for this patient? So if we don't do that, that patient's forever going to think that they have no variation. So anyway, I hear this all the time. Your DNA doesn't change. You test once for your genetics once. It's good for life. Insurance companies only want to pay for only want to reimburse for one genetic test, never to do it again. We say this all the time. You got a test. You're done. But is that really true? Our knowledge is growing all the time. We're finding new alleles, and so I say that maybe this test is not for life, and maybe at the very least, if you got a test where you were star 1 for something, that you should really think about, or your clinicians should really think about retesting as time goes on, because maybe, just maybe, there's something in there that we didn't know about before. So these tests, the transparency is critical. We need to have better transparency in what the actual test result, what the test tested for, what's missing, what didn't you test for in your test? That's really important for people to know, right? If you get a star 1, but you only tested for 2 alleles, it's like that warfarin example. Oh, you're not a star 2, you're not a star 3. We're just going to say you're a star 1. And we know that's not true. So we need to know if the genetic information is there, please let's use it. And if there's genetic information missing, let's be transparent and tell people this. And if the results are ambiguous, which it happens, maybe we should just say so. I understand it's scary and it's messy, but I think that we can educate people. I think that both the medical community and the lay public can understand this if it's told to them in a way that they, that if they're explained, they'll be able to handle it. And then my last point is, I would say maybe it's time to stop reporting a star 1 as a test result if we just don't find a few variants, and maybe we just say no variants are found. So I just want to end on a few things that we should think about when we're doing pharmacogenomic testing. What populations were studied that were used to build the test at hand? What is the population being tested? And how does that matter? What alleles are tested? How are these validated, interpreted, and reported? What does a negative genetic test really mean? And when should we be retesting or reinterpreting testing in pharmacogenomics? So I think my time's up. Thank you. I just want to thank everybody for their attention, and many thanks to all the people I work with, my team at our Gecko team at Stanford, PharmGKB team, all my colleagues, and especially conference organizers. Thank you.